Some brief housekeeping. In the webinar format, attendees' cameras and microphones are disabled. If you have any trouble hearing us, please adjust your audio settings. There is also an option to be able to call in to use your phone instead of the computer audio to listen. This webinar is being recorded and a copy of it will be made available, as well as the slides will be shared after the webinar. We do have a chat box, so please add in your comments. Again, please take a moment to introduce yourselves. We love knowing where you're joining from. There will be a Q&A at the end of the webinar, so please submit your questions in the Q&A box. This allows us to easily find your questions and so they don't get lost in the chat. And with that, I'm going to hand things off over to Julia.
Thanks so much, Alyssa. I'm Julia Skapik, the CMIO for NAC, and I'm really pleased to be able to bring an absolutely fantastic panel of experts today to talk about health centers and the response to the monkeypox outbreak in the United States. You can go to the next slide. So I wanted to put the NAC mission up here just to call out that I think, the components of the NAC mission about being accessible, culturally and linguistically competent, patient-centered and community-directed are all really key aspects of the monkeypox response. And I think health centers are particularly well suited to respond in a way that really meets the needs of our patients, many of whom will be underserved and people who traditionally experience health inequities. You can go to the next slide. This work also fits strongly with NAC's strategic pillars. Obviously, we're thrilled to have the National Monkeypox Coordinator and Deputy Coordinator here with us from the White House, as well as the Director for HIV/AIDS Policy. That's part of our supportive partnerships, but also part of that is working directly with you and with your partner PCAs and HCCNs to help identify those successful models of care, those best practices, and then scale them across the infrastructure for health centers in a way that's really equity and social justice oriented. We know that health centers already have a high level of skill and mission-driven work around HIV, STIs, sexual health, and also LGBTQIA issues. And so we've brought some of the health centers who are really innovative in this area to tell us what they've been doing as part of this response. You can go to the next slide. So these are actually not all of the people we'll have joining us on the webinar today, but these are the folks who will be giving us more formal presentations. We have the National Monkeypox Response Coordinator, Administrator Robert Fenton, with us from the White House, along with his Deputy Coordinator, Dr. Demetre Daskalakis. They're bringing with them also Harold Phillips, the Director of the Office of National AIDS Policy. And then to hear more from the local and community health center experience, we'll also hear from Anthony Fortenberry, with Colin Lord, and Kevin Ard, who works closely with Fenway Health Centers and is the Director of the National LGBTQIA+ Health Education Center. At the end, we'll be joined by some additional experts who will be able to answer questions from a number of different viewpoints, including an expert from IDSA, which is actually going to be represented by Kevin Ard, and also the director for the STI Center, National Center, as well as someone from HRSA to talk to us about some of the policy issues that affect health centers and some of the programs they have to support them. You can go to the next slide. So here's our agenda. As we mentioned, we'll get an update from the White House team, and then we'll hear about the health center response and some challenges and successes in outreach, education, presented by Dr. Ard, and then we'll close out with an Ask the Expert session and a brief policy update from NAC's policy team and close out. This will be a 90-minute session with our goal of having at least 35 minutes for this Ask the Experts Q&A time at the end. So please be ready to put questions in the chat or optimally in the Q&A section, and we will try to get to those as quickly as we can at the end of the session. Thanks so much for joining us today, and thank you to our presenters. You can go to the next slide. And I'll turn it over to the National Coordinator and Deputy Coordinator for the National Monkeypox Response. Thank you so much for joining us.
Hey, appreciate it, Julia. Thanks for having us on. My name is Bob Fenton, and just wanted to just start by thanking everyone for being on today. This has really been a whole nation effort, and community health centers are critical part of this team in order to ensure we get everyone vaccinated. And while we made remarkable progress over the last couple of months, and the number of cases on average continue to go lower, it's really reaching out to those now that are the highest at risk to ensure equity. And your health centers, I think, are going to be critical to reaching those communities. I'm going to turn it over to Dr. Daskalakis to provide some slides to kind of give you some information and our strategy and where we're headed. With that, thank you.
Thank you, Mr. Fenton. So next slide, please. So we'll briefly go over a situation update, talk about the current epidemiology of the outbreak, focus on some of our recent updates and on our response pillars, including testing, vaccine, treatment, and our communication and outreach work. Next slide, please. So first, the situation update. So as of November 1st, there have been 28,442 cases in the United States. You can see on the map, the areas that are darker blue represent a higher number of cases within the state. We continue to see activity for monkeypox across the globe. 77,000 cases have been reported to date internationally. Next slide, please. This is our epidemic curve for the current outbreak in the United States. The red bars represent cases reported every day, and the blue line represents a 7-day daily average. The fluctuations that you see really are based on reporting. The big dips that you're seeing are weekends. Folks tend to see care less often over the weekends, and also jurisdictional reporting tends to be inconsistent over the weekend as well. So what you can see is that we have decreased the number of cases by about 85%. Compared to the peak of the outbreak, and that trend continues. This will be updated later on today at CDC on their website. Next slide, please. I also wanted to highlight that we have some technical reports. We're actually up to technical report number 4, but they actually do reflect very similar information. So you will see that there's a breakdown of the epidemic curve by race. That is the graph on the left. There's also a model that shows our effective reproductive number, which has been under 1 since early to mid-August. So effective reproductive number under 1 means that we have a shrinking outbreak, which is great news. And even as the data becomes, or as the model has less certainty, it continues to look as if most of the model really reflects an under 1 effective reproduction number. Additionally, there are graphs that show epidemic curves state by state of our states with the highest number of cases historically. Next slide, please. Also on the technical report is a view of rate. Using the denominator of men who have sex with men, either who are PrEP candidates or people living with HIV. The darker the red, the higher the rate in that population on the map. Additionally, there is an estimate of the percentage of eligible population who's been vaccinated with 1 dose of vaccine. That is higher than this, given that this graph ends in September and it's from technical report number 3. It is over 40% to date. Next slide, please. So just briefly going over the current epidemiology, the majority of cases are in the 31 to 35 age bracket. Most are men, that's the navy blue color, although there are other gender identities reported. 96% specifically are men, cisgender men, 2.6% are cisgender women, 0.2% are transgender men, 0.7% transgender women, and then a little bit under 1% reporting another gender identity. Next slide, please. Looking at the outbreak over time, it is notable that there is a concentration of cases occurring among Black and Latino individuals. So though the total number of cases continues to decrease, the proportion that are in Black and Latino individuals has increased over time. Next slide, please. Also, if you haven't seen it, on the CDC website is a graphic that shows that the various symptoms that people can have presented with in our case reports. It's notable that about 40% of individuals present with rectal pain. Next slide, please. So we'll move on to updates. And so I think we'll be hearing from Harold Phillips later, but I'm going to sort of frame some of his comments by sharing some important data. So monkeypox is not an infection that exists in isolation. When looking at monkeypox in 8 jurisdictions using a match of their registries, 38% of individuals diagnosed with monkeypox also were known to have HIV. 41% had a diagnosis of an STI in the year prior to their monkeypox diagnosis, and about 60% either had HIV or that STI history. So it really raises again to our consciousness that monkeypox exists as an interacting outbreak or interacting epidemic, something that we often call syndemics. And the syndemics here include HIV, include STD, as well as important social determinants such as housing, as well as mental health and drug use. Next slide, please. So I won't go over the slide in a lot of detail, but it references MMWR, the same one. They really talked about severity of symptoms. So some really important things to note is that people living with HIV were often reporting more severe symptoms and were more likely to be hospitalized. Next slide, please. When looking at those individuals living with HIV and what the control of their HIV infection looked like, individuals who had less good control of their HIV, so who had a detectable viral load, had some increase in certain symptoms, but notably also were significantly more likely to be hospitalized. So you'll remember it was 8% for all people living with HIV, but for those that have a detectable viral load, it was 27%. Similar data for individuals with lower T cells, and lower here is defined as less than 350 T cells. And so 15% of those individuals were hospitalized. Next slide, please. A more recent MMWR released on October 26th reported out on 57 severe cases that CDC was consulted with. And this, I think, really highlights the importance of approaching monkeypox within the syndemics that it exists. 82% of those 57 people had HIV. 72% of the people living with HIV in this small cohort had CD4 counts of less than 50. Less than 9% of them were on HIV medications. Almost 70% were Black and 23% were homeless. And so really stepping back, this really demonstrates the role of the HIV infrastructure to address monkeypox, but also the importance of HIV testing, linkage to care, and also preventative interventions like pre-exposure prophylaxis to either control or prevent HIV. Next slide, please. So beyond data demonstrating that monkeypox doesn't live in isolation, that data has led to programmatic shifts in the way that we're responding to monkeypox. So Ryan White, through the HIV/AIDS program at HRSA, CDC through its HIV and STD divisions and funding opportunities, and SAMHSA have all released letters that really inform grantees that they can and should use their resources, both human resources as well as fiscal resources, to address the monkeypox outbreak. So really making the point that monkeypox lives in a syndemic, so we have to treat it that way. Next slide, please. Most recently, there is HUD and HOPWA also released a very important letter that gave a lot of detail of how these resources can also be used to support people who are diagnosed with monkeypox. And remember, again, 23% of the people with severe monkeypox have been experiencing homelessness. So the opportunity to use these resources to support people with monkeypox and also the baseline need to support them, I think, are highlighted in this HUD-HOPWA letter. Next slide, please. We continue to look for strategies to fund monkeypox. There was a supplemental request that went to Congress that was not approved for $4.5 billion. Some of it, almost the majority of it, $3.9 billion being domestic, and about $600 million to support global efforts to combat monkeypox. So we continue to look for opportunities to not only leverage current resources, but also identify new resources to make sure that we accelerate the end of this outbreak. Next slide, please. So now we're going to move into the pillars, and first, testing. So the story of monkeypox testing early on had to do with the laboratory response network laboratories. So these are the public health laboratories that were a part of a network really initially designed to address smallpox as a biothreat. So at the beginning of the outbreak, we had about 6,000 tests that could be done per week through the laboratory resource or LRN network. Subsequently, the labs were commercialized. So CDC worked with several providers of laboratories, commercial laboratory tests to integrate monkeypox testing into their portfolio. So that then resulted in an 80,000 tests per week capacity for monkeypox. And what you can see is that we've done about 121,000 specimens that have been tested so far. Overall, the cumulative positivity rate is about 28%. And given the fact that we're seeing a decline in monkeypox cases, and that means lesions to test, we're also seeing that there is significant capacity available should there be a surge in new cases. Next slide, please. So I'll move on to vaccine. I'll first tell you about a really great infographic that is responsive to what we heard from the community. This infographic that's available on the ASPR website, but you can also access from the HHS monkeypox splash page, shows really in a very transparent way what our vaccine supply strategy is in the United States. So if you visit this every Thursday, it's updated, tells you what vials we've ordered, what vials we have in the strategic national stockpile, what vials have been distributed, and also what's been administered. The graph on the upper right shows our projections for what we expect to come based on orders, as well as the tempo of vaccine becoming available or being shipped. The dark line there actually represents what we've gotten so far. And there's a map to the left that shows distribution of vaccine, and a map to the right that shows actually where vaccine has been administered. Next slide, please. We continue to see vaccine numbers increasing. We have seen over 1 million doses of vaccine administered in the US so far. The graph below shows you what a leveling off of demand looks like. So you can see that we continue to have first and second doses of vaccine being administered, but decreasing numbers, which again is, I think, a highlight of a place where we definitely need all the support from community health centers who have access to vaccine or who can navigate people to vaccine, because we really want to get those first doses in, and we also want to make sure that second doses are also in arms. We are seeing a fair amount of success with second doses, with nearly 60% of individuals who are eligible for their second dose having received the dose during our last analysis of these data. Next slide, please. When you look at the vaccine administration story, however, there is a disparity that is really the converse of the disparity that we see in cases. So remember, in cases, we were seeing that there was an increased proportion of cases among Black and Latino individuals in the US. What we see in vaccine is that the majority of shots have gone into the arms of white non-Hispanic individuals. So a lot of work, which we'll talk a little bit about here, focused on trying to increase vaccination among Blacks and Latinos, given that they are overrepresented in the outbreak and underrepresented in vaccine administration. Next slide, please. There is progress, however, looking at the time period of May 22nd to June 25th versus July 31st to October 10th. There's been about an 8-point increase in the proportion of vaccines that have gone into Latino arms, and over doubling of the proportion of vaccines that have gone in Black people's arms. So I think though that is hopeful progress, we really are working to speed this up so that we can address equity in a more complete way. Next slide, please. One strategy that we learned through our vaccine confidence report, which I'll talk about briefly, is being transparent about what we know about the vaccine. One example of this is the release of vaccine performance data from the CDC. They have actually released the first swath, the first tranche of data available for the Jynneos vaccine. This will update over time. It is sort of a rolling process, and it will update as more data are available. But as of the last look, a very important message is that individuals who are vaccinated were about 14 times less likely to get monkeypox than individuals who are not. So that really highlights the importance of vaccine. And that's only the first dose. And we know that the second dose, which is the more important dose, at least looking at lab-based tests, would provide even more protection. There are lots of caveats for the study. It's surveillance-based, so it doesn't capture some of the nuances of behavior, but still really hopeful early news in terms of the performance of the Jynneos vaccine against a real-world monkeypox challenge. Next slide, please. I also wanted to make sure I highlighted this confidence report. If you haven't seen it, it's really great to read. It is a baseline looking at what we are seeing and hearing in terms of issues around confidence for the Jynneos vaccine. So it also provides a lot of resources to address some of those sort of bits of misinformation or disinformation that may really help providers stimulate interest and confidence in the vaccine. So if you have not seen this, please do check it out. It's a great document. Next slide, please. Also, one of the things we wanted to make sure that we did in talking to you is that we wanted to make sure that you were aware that as of the end of September, the eligibility criteria for the vaccine have changed. So early on, when there was a supply and demand mismatch, really the focus was on post-exposure prophylaxis with a little extension into something that was called PEP++, which meant not necessarily knowing someone was exposed to monkeypox, but somebody, if they had the right exposures in a couple of weeks prior to vaccine, would qualify for vaccine. Now, with adequate supply of vaccine, because of both production side progress as well as the use of the intradermal dose, the strategy for the US has switched to a pre-exposure prophylaxis vaccination stance. And what that means is that gay, bisexual, and other men who have sex with men, as well as gender diverse or transgender individuals who in the last 6 months have had either a newly diagnosed sexually transmitted infection or more than one sexual partner qualify for vaccine. Additionally, anyone who has had sex at a commercial sex venue or in association with a large event in an area where monkeypox transmission is occurring would also qualify for vaccine. Additionally, any of their sex partners, and also shouting specifically out commercial sex workers, qualify for vaccine, as well as anyone who may be anticipating experiencing the above risks in the future. So not only what happened 6 months ago, but what could happen in the future would qualify folks for the vaccine. So a way more liberal strategy for vaccine, for people to qualify for vaccine. Next slide, please. And also focusing on some of the feedback that we've gotten, a lot of effort to mitigate stigma. So rather than doing extensive risk assertions for people who are looking for a vaccine, if someone says they need the vaccine, we can back off and not really grill them for more information about their lives. This is a barrier that we heard early on in the vaccine effort. So if someone wants a vaccine, that is in effect implicit that they qualified if they've reviewed the list of what would put them at risk. Additionally, some people didn't want the vaccine on their forearm. So we've been, because it leaves a temporary mark, we've been able to move the sites on people's bodies where they can get vaccine. And that includes, well, the next slide. Another that we're in the midst of through is really increasing availability of vaccine by using retail pharmacies. The PrEP Act that focuses on smallpox was amended, allowing for the administration of monkeypox vaccine by pharmacists and other staff in pharmacies. So we're currently working to launch this specifically focused at pharmacies that have experience with populations who are overrepresented in this outbreak. Next slide, please. And I won't go into this in detail, but that is happening, funded by the NIH, that I believe is fully enrolled, looking at the lab immunology of various dosing strategies for the Jynneos vaccine, including the subcutaneous strategy, the intradermal at the current dose, as well as an intradermal half dose to see if that one still stimulates the right immune response while potentially having fewer side effects or maybe even a less longer lasting spot that some people complain about after the vaccine. Next slide, please. So we're going to move on to equity, and this really focuses on vaccine equity. So 2 pilots that have now merged into one have been launched to increase vaccine supply to jurisdictions interested in doing specific equity-focused intervention, whether they're in large venues or smaller interventions that may reach populations deeper. Really moving this from a build it and they come to how can we get vaccine closer to people. Next slide, please. There have been some great examples of these, so I won't go over them in detail, but we've been all around the country doing all sorts of vaccine efforts with local jurisdictions, Black Pride in Atlanta, Southern Decadence, Las Vegas Pride. So I think one of the highlights, and I dedicate this to Bob, is that the Castro and Folsom Street Fair did 10,000 vaccines in 2 weekends. So a pretty remarkable amount of vaccination in these non-vaccine focused events. Next slide, please. If you want to read more about Atlanta Pride or you want to read about Southern Decadence, there are MMWRs that give a deeper dive so you can see what was learned on the ground. Again, you can see many thousands of people have been vaccinated through these efforts to reach people where they are. Next slide. I want to just, again, highlight some of the work that we've done in communication. So really creating transparency, as well as using frank language that is clear and understandable to the communities that are affected by monkeypox has been one of the cornerstones in the work that we've done. Next slide, please. And we've seen really great effect, not only by the communication that comes out of public health, but also what happens when good public health communication stimulates the community and providers to give really good advice to their patients. The effect of this is that we have seen that people who are at risk for monkeypox, specifically gay, bisexual, other men who have sex with men, have reduced some of the behaviors that are associated with monkeypox transmission. And this is an MMW, this is a CDC supported study, but there are other examples, one from University of Texas that shows about a 56% reduction in risk behaviors among transgender and transgender folks and men who have sex with men. So really the messaging worked. And the community's mobilization, I think, is part of why we're seeing the decreases. So natural immunity, vaccine-induced immunity, and behavior change all come together to make that curve go down. Next slide, please. I'll also just highlight that, that in order to achieve the end of an outbreak or an epidemic, you need 3 ingredients. You need science, political will, and community engagement. So I think we talked about the science, but really to make the point that there's a lot of will to engage with communities and so much robust community engagement to make sure that we're hearing exactly what we need to do to further tailor the response so it is more responsive to community needs. Next slide, please. And part of that also has included convening a group of or LGBTQ perspective at the White House for workshops to really hear from the front line what people's needs are and where we can calibrate our response to further address their needs. And you can see Admiral Levine has been a part of them. So our Assistant Secretary of Health, as well as Kay Hayes, who works in that office as well and is our equity senior advisor. Next slide, please. We continue education, not only of people on the street, but also providers. There's some great technical reports. We highlighted technical report number 3. Technical report number 4 is out. Check it out. Also a science brief. And if you have not seen that, there's a table that really goes through various types of exposures and comments on the presence of detectable virus through PCR, detectable virus through culture, as well as is this a mechanism that epidemiology supports is associated with monkeypox transmission. If you haven't seen the table, it's coming up on the next slide. It's worth taking a look at. We also do these COCA calls, clinician outreach, et cetera, to make sure that we communicate. This is a table I refer to. Check it out when you have a chance. I won't go over it in detail. Next slide, please. And then moving on to treatment, we continue to work on tecovirimat, which is a drug that is accessible through an expanded access investigational new drug application from the CDC. You can see that the majority of people who have been treated with this drug through this EAIND are male and really reflect the demographics of the cases. Next slide, please. And that actually also plays out in the race ethnicity breakdown. This has less of a disparity than what we see with vaccine, although there is still a disparity with Black individuals still underrepresented compared to the percentage of cases they make up. Next slide, please. Also important to just remind you all that there is clear guidance for use of this drug online, and the expanded access IND is pretty straightforward. It is about a 21-minute process to be able to fill out the paperwork to get access to the drug for someone who has monkeypox. Next slide, please. But in the meantime, it is also important to note that there's a study currently recruiting that is called STOMP. It is our chance to see what the effectiveness of this drug is in the real world. So please do check out the STOMP trial. Next slide, please. These are the websites if you want to check it out. And if you do have patients, there's actually going to be remote consenting that is going to be added to this protocol. So it will be very easy for our patients to enter the study. And what's really important about this study too is that the expanded access IND really focuses on people with very severe disease. This study is not about just severe disease. If someone has monkeypox, they qualify for the study, whether it's mild or severe. It is randomized and controlled, but also has an open label element. So if someone has severe monkeypox, they don't get placebo. They can go right into an arm where they're going to get tecovirimat, and will still give us important data for how the drug works. Next slide, please. And speaking of research, for those who are inclined, there's a website that is accessible through the HHS Monkeypox Splash page that actually goes over all of the US government-funded research projects that are happening in monkeypox. It's going to be updated quarterly, and it's searchable by topic as well as agency. And I think that's my last slide. And I'm going to hand it back because I think we're going to have Harold say hello in a couple of words before we move on. Harold Phillips, I think, is up next.
Thanks, Demetre, and thanks, everyone, and thanks for pulling this together. I think as you've heard, we have a good story to tell when it comes to monkeypox, but we also are not done. And I really both want to do two things. One, thank the community health centers for the work that you've been doing, both in implementing the Ending the HIV Epidemic Initiative and the work that you've done to scale up both HIV testing and access to PrEP, as well as linkage to care. It's been really impressive to see that data. I think monkeypox gives us an opportunity to think comprehensively about a endemic approach and using the infrastructure that already exists within community health centers to reach those who are at risk for HIV. And as detailed by Dr. Daskalakis as well as Bob Fenton, those populations that are at risk for HIV are also at risk for monkeypox. So I really encourage you to think about what you've heard today and think about how we screen for both, and think about a comprehensive approach that works to link individuals to vaccine as well as treatment, especially as we are screening for other risks such as HIV and other STIs. You all have done phenomenal work when it comes to working within this space, and we encourage all of our partners, not only you all, to help us get to the last mile when it comes to monkeypox. We're close, but we're not there yet. I'm really focused on those populations of African American, Latinx, MSM, those living with HIV who might be out of care, and our homeless population as well. So thank you. And now I will turn it back over.
Hi, good afternoon, everyone. This is Anthony Fortenberry, Chief Nursing Officer at Callan Lord Community Health Center. I have a few slides that I'm going to go over very briefly here. I mean, that was just such a comprehensive overview of where we are in managing MPV. I'm just going to share some strategies that we found to be useful in Callan Lord's response to MPV, really with the focus on community partnerships, and health education. I think communications were such an important component of our clinical strategy, and so I'll also share some of our communications as well. I won't go into, of course, these bullet points of the overview of what MPV is, but I think it's important that this is what we were trying to get out, not only to our patient population, but importantly to our clinicians. I always think that the first line and the best strategy and an approach around dealing with an outbreak in a community health center is triage. We wanted to make sure, and this of course were lessons learned during COVID, that patients that are symptomatic are being isolated in a non-stigmatizing way, but being appropriately, that the clinicians that are going to be providing urgent care and doing assessments are appropriately notified so that appropriate PPE can be allocated, and so that the patients coming in are well cared for, as well as the staff and the other patients in the building. To achieve that, we used a communication strategy that was both in digital signage, as well as a text message strategy, and also just education for all frontline staff, importantly focused on the front desk, focused on the call center, focused in triage, giving very basic information about what MPV is, how it is spread, and I think importantly, how it's not spread. We wanted to make, first and foremost, an effort to decrease stigma around MPV and create a safe space where patients felt comfortable calling in or coming to the center for questions. This is another slide that we use specifically focusing on stigma, really using language around, not blaming or shaming anyone around questions related to MPV, to have conversations with partners around status or unusual rashes or any symptoms, and of course to engage with a healthcare provider that can help connect to services. We also had a lot of concerns around occupational safety, which again goes to providing information to the staff that are managing possible MPV infections, and ensuring that appropriate PPE, training around donning and doffing of PPE is all a core component early on in your strategy. Of course, we were already managing a lot of PPE due to COVID, so this was just additional PPE. I will say one strategy that was important is that our triage nurses, prior to any patient coming on site that was symptomatic for urgent care, and as Dr. Daskalakis had mentioned before, the symptoms of MPV often mimicked or very similar to other, STI-related symptoms that we would normally see. And so if a triage nurse was assessing someone who might have contracted MPV, we would err on the side of caution and flag that chart so that when that patient was checking in, the MA that was going to room the patient and do vital signs, the medical provider going in to do the urgent care assessment or specimen collection would have the appropriate PPE and manage that situation as though it was a rule out MPV as opposed to, our routine STI screening. Also, the previous presentation went into MPV morbidity and mortality and considerations around that. Co-infections are a particular training point, I think, both for nursing staff as well as providers, to ensure that you are erring on the side of screening for MPV during your routine STI screenings in the event that someone may have been exposed, whether they are symptomatic or not. Certainly, we saw earlier on in the summer that our patients living with HIV were experiencing more severe MPV infections and needing TPOXX treatment at higher rates than our general population. At Callan Lord, a little over 25% of our patients are living with HIV. So I think that's something to take into consideration, for your health center. But certainly for us, that was a large concern and something that we really flagged early on as an important consideration for our patients that were coming in for screening or treatment. Of course, also, equity considerations around both access to vaccination, which I'll get to in a second, but also around TPOXX treatment was an important consideration to ensure that we were doing targeted outreach and ensuring access to evaluation and treatment for cases that were appropriate for TPOXX were a focus. And I think an important part of that is creating data collection strategies so that you are holding your organization accountable and ensuring that the access being created to these services has a health equity lens and a health equity evaluation. So just going into TPOXX, access to TPOXX has gotten easier and easier. We have a lot of people to thank for that. And it's a really wonderful thing to see. At the same time, I do, want to emphasize the importance of creating infrastructure internally around access to TPOXX. This goes into, of course, building a very strong relationship with your local departments of health around, any resources that may be available for TPOXX access and facilitation. But I will say one of our earliest lessons learned was not to lean on your medical providers for the administrative burden around TPOXX access and facilitation. We really tried to pull administrative staff that could help to go through the paperwork and help patients really negotiate that process. You don't want your medical providers to be pulled from patient care in order to do this work. It's not necessary. However, I think administrative staff to help support this can be really, really helpful. That goes into our vaccination process as well. We utilized administrative staff to help with outreach and education. We have a team within our nursing department of administrative staff who do a lot of HIV outreach and education and testing. And so utilizing those same skills to do the work around answering questions for the Jynneos vaccine and doing outreach and education was really helpful, of course, with the oversight and easily accessible clinical resource if there are any specific questions. Another consideration here is around intradermal administration, not only providing education to the nursing staff so that they are able to answer questions, but also providing talking points for your call center, creating a site on your web page that the call center can refer patients to if they have questions was really helpful. We, of course, are in the middle of an enormous healthcare workforce shortage. And so getting a clinician on the phone to answer very specific questions can be a real challenge. And so having those kind of additional resources that patients can be referred to for FAQs or administrative staff that have talking points that patients can more easily access when clinicians may not necessarily be available is really important. And then, of course, at the end of the day, making sure your nursing staff that are doing vaccine administration have those resources as well so that they can answer questions in the moment. This is another, speaking to having some mechanism for data collection early on in the outbreak when we were referring patients to our local Department of Health for vaccination rather than doing them in-house. We did robust data collection around all of our referrals. We wanted to, again, hold ourselves accountable to the patients that we were referring for vaccination to ensure that we were, as much as possible, maintaining vaccine equity around access, which is incredibly difficult to do whenever resources are scarce. Once intradermal vaccination administration became available, that scarcity decreased to such an extent that it was more about outreach and access than it was about referrals. So we kind of, were able to evolve our strategy as administration options became available. But earlier on, I think this strategy was really important, not only to demonstrate our efforts around maximizing vaccine equity efforts, but also creating, some mechanism by which to keep an eye on the work that we were doing in this outbreak to maintain equity. I believe that is my last slide. All right, thank you so much.
Thanks so much, Anthony. Could we go to the next slide? Dr. Ard?
Thank you. Hello, everyone, and thank you to the organizers for inviting me to speak. My name is Kevin Ard, and I'm the medical director of the National LGBTQIA+ Health Education Center at the Fenway Institute, and also the director of the Sexual Health Clinic at Mass General Hospital in Boston. And I'll be talking about some really frontline challenges and successes from my view in those two roles. So first, I'll say a bit about our experience. The first US case was identified at our parent institution, Massachusetts General Hospital, on May 18th, 2022. And so in some ways, we had a little bit of lead time thinking about this diagnosis and what this might mean for our clinics in comparison to some other parts of the country. This shows the epidemic curve for Massachusetts, which is very similar to the national curve, but there was that one case there in the middle of May, and then a rapid rise in cases peaking in late July and early August, and then declining since then. Within our sexual health program, which has locations at a health center, also at a hospital and at multiple community partners around Boston, we began providing testing and treatment and vaccination that was headquartered at our main site. And at the kind of height of that epidemic curve, we were testing and treating up to 4 people per day, which for our small clinic was a big lift. These tended to be lengthy visits lasting at least an hour. We got a little bit faster as we became more experienced and various processes were streamlined. But it did require quite a bit of staff time. In addition, we were one of the first 4 sites in Massachusetts that offered the vaccine through our local Department of Health. The vaccine demand was immense, as you have heard across the country. Our clinic volume essentially increased overnight 5-fold, and we'd given more than 5,000 doses of the vaccine through last week. And so what were the challenges that we faced, and how did we overcome some of these? Well, certainly there was the operational and the logistical complexity of all of this. We, of course, had no dedicated staffing for monkeypox prior to the outbreak. There were space and staffing constraints. Preventing and addressing staff burnout was, I think, a key factor in this as well. All of a sudden, people had much more to do, and so making sure that staff were adequately supported was crucial. We also were concerned about minimizing the impacts on other core services, on provision of PrEP, on STI and HIV testing, on STI treatment, not just for people who did not have monkeypox, but also for those who did, making sure that we were thinking about engagement in HIV treatment if that were warranted, engagement in PrEP, and testing and treatment for STIs for those individuals. Another challenge was embracing and communicating rapid change and also minimizing stigma and its impacts. And I'll focus more on these 2 challenges in the remainder of my time. For us, the response to monkeypox really meant adapting and embracing rapid change. So this is a short and not complete rundown of what has changed since May of 2022. One thing is simply clinical reasoning. I would venture to guess that most clinicians did not have monkeypox on their differential diagnosis prior to May 2022 in this country. And of course, now that's different. We have to think about this when patients come with a rash or other compatible symptoms. Of course, there have been immense changes in our clinic processes. You heard about infection control procedures and so forth, and also just the volume of patients seeking care for confirmed or possible monkeypox. It's gone up, and then it's also come back down. Testing has changed. As in many locations, we initially had to obtain approval from our local Department of Public Health to test any individual patient. That's now gone away, and we're mostly sending testing to commercial laboratories. But with each change in testing, there have been some different instructions, sometimes different tubes and so forth that have to be used. You've heard about treatment. The IND process has become much simpler, and that has been extremely helpful. And also the treatment considerations for tecovirimat have changed slightly. And so making sure that everyone is updated there. And then there have been developments in vaccine strategy and eligibility and in route. And so just using the example of vaccines for a moment, this is the evolution of the vaccine effort in Massachusetts and in our clinic over the course of a couple of months. Initially, we were providing vaccines through a PEP and PEP++ strategy. So for those with confirmed or presumed exposure to monkeypox, that then shifted to PEP and PEP++, but also to pre-exposure prophylaxis, as Dr. Daskalakis reviewed. Initially, very early on, we were providing a 2-dose subcutaneous series. Then Massachusetts switched to a first dose prioritization scheme. This was not recommended by CDC or FDA, but it was undertaken in many parts of the country, including Massachusetts. And the idea was that people would get 1 dose of the vaccine and then get a second dose when supply permitted. And so for a brief period of time, we were doing that approach in accordance with our local public health guidance. With the switch to intradermal, we were then back to a 2-dose series. And then again, that's evolved further with pre-exposure prophylaxis vaccination. So what strategies have been helpful when adapting to this rapid change? Well, one, and we learned this from COVID, was to engage key decision makers early on and often. One need we had, for example, early on was a standing order for the vaccine. That procedure might typically take weeks to go through the various committees that would review it, but it happened within 24 hours because we were able to talk to and engage the folks who had to make the decision about that. This may seem like a small thing, but version control becomes a big issue when you're thinking about rapidly changing processes. And so having one electronic source of information for what the process is at any given moment was extremely helpful. You've already heard about communication. And I think some important things that we learned from COVID and then were able to implement during this outbreak is to prepare patients for change. Early on, we told patients, we are booking you for a second dose of the vaccine at 4 weeks. It's possible, based on what we're hearing from our public health colleagues, that may need to be deferred depending on supply. So we prepared them for that eventuality. I think it's also important that we convey recommendations to patients with the appropriate level of confidence. And saying, based on what we know now, this is what we recommend. And that may change in the future, but this is the recommendation based on the best available evidence at this time. And then also staying up to date with shifting public health guidance. We had the experience that whenever something was updated on the CDC webpage or reported in the media, that patients would start calling about it right away, often before the staff had had a chance to review the information. And so as much as possible, trying to stay up to date. The other challenge I want to mention that has already been addressed a bit is minimizing stigma and its impacts. And of course, stigma has several different levels. It could be structural. It also could be internal, where people may internalize self-loathing or feelings of guilt or blame. One key aspect here, as the other speakers have emphasized, is to provide information in a clear, fact-based, and sex-positive manner. And I really want to applaud the examples you saw from Cowan Ward and also the Safer Sex information sheets from CDC that I think really accomplish this task. It's also important to avoid processes that may publicly and unnecessarily out people who are seeking care. One example, which may be hard to avoid in some cases, is those long lines that you may have seen in the newspaper or on the news of people who were lining up for the vaccine early on. And of course, people might infer someone's sexual orientation from their presence in that line based on the vaccine criteria at the time. And of course, we want to make sure that people who may not feel comfortable being in such a line can still access the vaccine, as Dr. Daskalakis mentioned. Of course, minimizing stigma is not just something that happens in terms of our communications externally, but also with patients, also in the exam room. And I was really struck by how when we would see patients who were coming for testing or treatment, and we said, we're sorry you're sick, and we'll do our best to help you feel better, that some patients started to cry and said that they blamed themselves for this, or they felt that they deserved it. And so I think that speaks to really how deep and pervasive some of the internalized stigma could be. And then, as Dr. Daskalakis mentioned, also administering intradermal vaccines at alternative sites like the upper back or the deltoid, if requested by patients. It's also important to have simply environments that are welcoming and affirming for all types of people who may be at risk for monkeypox, including LGBTQIA+ people. So in summary for this portion, health centers have played and they will continue to play a key role in response to monkeypox. And responding effectively to outbreaks like this one requires that we embrace and adapt to rapid change, that we communicate effectively, including with our patients, and also address stigma. Thank you. I'll now turn it over to the next speaker.
Wow, that was a really good conclusion, Dr. Ard. I think talking about how we can, make our outreach efforts more successful. I'd like to invite a couple more folks to join the speakers we've already heard from on the Ask the Experts extended panel. First, we have Nehar Mufidi. He's the director of the Division Community HIV/AIDS Program at the HIV/AIDS Bureau at HRSA. And we'll also have Rachel Deach with us. She's the Director of Federal Policy at the National Coalition of STD Directors. And I'm sorry if I reversed up her title earlier in the presentation. Dr. Mofidi had asked if he could tell us a little bit about some of the resources that HRSA has to offer in this area, which I think is a great start to Ask the Experts. So let's go to the next slide. We'll hear from him for just a couple moments, and then we'll get
actually,
started.
we're gonna
What's the
stay
question?
on the previous slide. Yeah.
Sure.
We'll get to the resources in a few minutes, and thank you and good afternoon, everyone. It's wonderful to be in this space and to learn about the novel approaches that are being implemented in this public health response to the most recent public health emergency, monkeypox. As trusted providers, many health centers are helping to respond to the outbreak in their communities, and over and beyond monkeypox as frontline providers of healthcare. Because of you, people in need have access to high quality health services. I'm the director of the Division of Community HIV/AIDS Programs at HRSA's HIV/AIDS Bureau, and we support over 500 urban and rural Ryan White funded community-based organizations, many of whom are health centers. So I know how dedicated and how hard you all work to ensure access to quality healthcare services. Just to reinforce the comments made earlier by our presenters, the recent studies, including MMWR, coupled with what you have seen and heard on the ground, really underscored the need to respond to this monkeypox outbreak as a syndemic, as was mentioned, interacting epidemics by aggressively and comprehensively addressing monkeypox, HIV, STIs, homelessness, stigma, as just was referenced in the previous presentation. We have recognized that monkeypox is not a virus that lives in isolation. It exists as a part of a number of acute and chronic outbreaks and health challenges that interact with each other and can be impacted by social circumstances. So as health centers, you're all well positioned to addressing monkeypox, to addressing this syndemic. You deliver comprehensive, high quality primary integrated healthcare services to the nation's most vulnerable individuals, including people who are experiencing homelessness. And so there are several implications for this public health approach to monkeypox. And again, in this regard, health centers can really play an important role. One is to continue to increase awareness about monkeypox. As the article recommended, MMWR clinicians, whether primary care or ID doctors, should consider early treatment with available therapeutics. Another implication raised in the report is for providers in health centers and clinics, testing all sexually active patients with suspected monkeypox or HIV at the time of their MPOX testing. Engaging all persons with HIV in sustained care is another public health implication. Using HIV care systems, infrastructure, like the ones at health centers to support people with HIV, of course, provides access to vaccination, diagnosis, and treatment, and can prevent poor outcomes with both HIV and monkeypox. I think another implication is that we must continue to use our existing HIV care systems, such as the Ryan White program, to support people with HIV, especially engaging them in care. Here again, health centers, you know how to leverage a variety of other health related programs like behavioral health in support of care and treatment of patients. It is also important to leverage housing resources, such as Department of Housing and Urban Development's HOPWAP program and homeless assistance programs to prevent and mitigate the cases of severe monkeypox, especially among people with HIV. Given the importance of housing as a determinant of health outcomes, housing services is an allowable service under the Ryan White program. And so many of the 57 patients in the study were out of care, and housing can be and should be used as a platform to get individuals who have been disengaged from HIV care to reconnect and to ensure HIV medication regimen can be obtained. Just a few words about HRSA's response to monkeypox outbreak. In August, HRSA was identified as a distribution point due to HRSA program's support of individuals with HIV and the large number of uninsured and underinsured patients of duly funded Ryan White and Health Center programs. So in August of this year, we received an allotment of a JYNNEOS vaccine for rapid distribution to Ryan White program recipients, duly funded health centers, to help reduce the outbreak among those most affected. And so these first JYNNEOS vaccine went to those duly funded health centers and Ryan White clinics that serve a significant number of men who have sex with men and transgender persons and are registered in HPOP systems. So having access to HPOP, of course, quickly helped us to quickly get the vaccine out to clinics and the clinics to the clients. So I just want to take time to say thank you to those duly funded recipients and everyone else for all of your efforts to help support your community in accessing these vaccines. We will reach out to other Ryan White Part C and duly funded health centers on a rolling basis should we receive further allocation of vaccine. Meanwhile, we've been encouraging recipients to work with their state and local health departments to access the monkeypox vaccine to meet the needs of their patients, whether they've been exposed or at risk. And many of you are coordinating very successfully with local and state health departments. Maybe we can now turn to this slide on resources. Thank you. So this is a list of our recent monkeypox technical assistance resources, including FAQs, information about the monkeypox vaccine distribution initiative of HRSA, and our monkeypox program letters which was referenced earlier. There's more information about the HRSA vaccine initiative on the HRSA website, which includes a list of providers who have received the JYNNEOS vaccine as part of this initiative. HRSA is encouraging our Ryan White providers to continue to partner with health departments and work together to address monkeypox in their communities. And as I conclude, our message is to our recipients, to these duly funded health centers and Ryan White clinics, is to manage monkeypox as a syndemic, increase awareness, vaccinate, engage in HIV care as soon as possible, and consider any suspicious rash, as a potential possible monkeypox. So we will continue to support your efforts to respond to these outbreaks, and we thank you for, again, your dedication to provide comprehensive care to your clients and all your communities. Thank you.
Thank you so much, Dr. Mofidi. So I think we'll turn now to the Ask the Experts Q&A. So our experts can feel free to volunteer to respond to specific questions. This first question is for our ID experts and clinicians. This was submitted actually in advance of the webinar, but if there are additional questions, please put them in the Q&A. So the question is, can a person have monkeypox and be asymptomatic? And I suppose it might be helpful to elaborate a little bit on those cases in which it's a little bit hard to tell because the presentation is atypical.
So, what I would say is that the case series of reported monkeypox, people have had symptoms. These are among people diagnosed. There have been a few studies, and one in particular that I'm thinking of from France, in which they subjected swabs that had been used to perform gonorrhea chlamydia testing to assessments for monkeypox virus. And that was found in a small number of people who did not have symptoms at the time of that testing. So, whether those individuals were simply pre-symptomatic or, truly had an asymptomatic infection, I think is not clear. But, by and large, people will develop symptoms during the course of this infection.
And I'll just add, this is another great reason to go to the science brief that I talked about, because it actually goes over this in some detail in terms of data levels. So it's also in the, it's in the science brief and then also referenced in the technical brief that I talked about. So please do visit those for a deeper dive. And it's a great question.
So I would assume this is probably for our federal partners. And the next question is, how should organizations plan to continue partnering with the administration in the event that Congress fails to provide funding? I would assume that means at least in the immediate term.
So I think this is the time to talk to your elected officials, especially if you're worried about monkeypox, to highlight the need for ongoing support. There will be other and additional opportunities for us to really highlight the need for new funding. So I think it's as those roll out, please continue to be engaged. Your voices are very, very important. So please, I think as we work to raise up monkeypox as something that requires new funding, please also, we ask that you do the same from where you sit, because again, as providers, especially as folks who are engaged with community health centers, your frontline experience is something that electeds take very, very seriously.
Thank you. That was really helpful. If anyone wants to,
one more thing. Sorry, one more thing. Also, just we still have the flexibilities. Those flexibilities are in place to leverage funds. So, especially you've heard from our HRSA colleagues that the HRSA funds are leverageable and that they support so much work for people who are living with HIV. But then also, if you are receiving support from CDC, those are leverageable funds, HIV and STD, SAMHSA funds, and then also you heard a little bit of, as I told you, and I think also we heard that HUD funding is HUD programmatic support is also available. So it's at this point, continue leveraging to give the right care and services that your patients need, and then continue to advocate with your electeds for new funding. Thank you. Sorry about that.
And just building on that, in terms of the Ryan White duly funded health centers, part of the flexibilities that have been enacted is that you all can use Ryan White funds to support monkeypox testing, as well as to pay for fees associated with monkeypox vaccine administration and treatment. And of course, if you have any staff that you want to reassign to monkeypox, because this is a public health emergency, you can use Ryan White funds for those.
Thank you for those insights and recommendations. So I think this is more directed towards our clinicians and health center partners. What strategies are or can health centers and healthcare organizations use to address the equity gap in vaccinations? So how do you take those outreach strategies to continue to have an impact on that gap? And I know, Anthony, you mentioned this in your presentation, but please feel free to follow up.
Yeah, I think it's been mentioned a lot around community partnerships with other CBOs, and that has been a really impactful strategy for us around getting messaging out there. I will also say, I don't know that I've ever worked as closely with our comms team as I have during this initiative, getting all of our communications to have multi-language translation, to use TikTok to get information out to a younger crowd. You know, COVID was very focused on older adults who were having worsened health outcomes. And for this, we were really targeting a younger population. And so also being able to be nimble and pivoting to, you know, targeting communications where populations are most apt to hear them was a new experience for us. And so, you know, using those kinds of social media was an important strategy in connecting our resources to those communities that we felt, you know, were perhaps less inclined to be, you know, first in line for a vaccine.
I agree with all those points, and I would just add also making as many possible avenues to access the vaccine as possible, walk-in hours, evening hours, weekend hours. And what we're increasingly seeing as well is that people who come for another service are eligible, and they're actually willing to get the vaccine. They're happy to receive it when it's offered, but they hadn't sought it out. And so having a pathway where the people come for another reason and they're identified as being eligible, or they express that they are eligible, simply being able to provide the vaccine right then.
I'll also add that, hi everyone, very excited to be here. Thanks for having me. That NCSD is in the midst of doing a slew of focus groups to really hear what messages resonate. And our first one was on vaccination. And it was primarily focused on Black and Hispanic men who have sex with men. I think that was 78% of the participants in the first focus group. And what we found, which was wonderful, was that they really trust messaging from their providers and from the CDC, particularly unvaccinated individuals who participated. And what they were seeking was more information, just generally, about the effectiveness of the vaccine, where to get it, and what to expect when they showed up for vaccination, particularly with the switch to the intradermal technique. There's just been a lot of questions of folks like don't know what to expect when they show up for their vaccination. And so what the messages we heard in our very first focus group, and I can share those results in the chat, was that we just need more messaging, more communication going out, because you all on this call are the folks that they are trusting, which is great. We've been talking a lot about whether or not there's mistrust driving some of this hesitancy, and at least our focus group didn't show that.
Yeah, and so Rachel, let me ask a follow-up question from the question list. You know, NAC had early on with the switch to intradermal administration heard that there were some members of the community who felt a little distrustful or concerned about whether or not the vaccine would be equally effective. I'm not sure if that that has sort of died down a bit, but just both at the patient level and at the organization level, are there any messages or strategies that you've used to help quell some of those concerns?
That's a good question. I actually think that's better answered by folks in the administration in terms of what messaging has been effective. I think from NCSD's perspective, it's the vaccine is effective and go get the vaccine. It's just the general, and then we drill down to great, go get the vaccine, and here's what to expect when you show up for your first dose. For folks who just, you know, they see the bubble, they hear that it's changed, they're just not really they're unsure on clarity of what to expect.
So I'll take my my cue from Rachel to talk a little bit about some of the strategy. So I refer again to that vaccine confidence report because it goes into a really deep dive in terms of what people were hearing. It was actually started a couple of weeks after the intradermal switch, so it captures like that very specific period of time. And you know, really what we were hearing was that the more transparency that we have on the decision-making process and on the effectiveness or performance of the vaccine, the better we're going to be. So a couple of things that happened right after the intradermal vaccine switch was made was that we within like a couple of weeks, the FDA put up a one-pager, this document that really goes through step by step, like what the thought process was and what the data were that supported vaccine intradermal administration, including actually referencing some German studies and then making them available in translation. I don't think that lots of people asked for them, but the fact that we were able to do it, I think, is really important. That also was supplemented by multimedia strategies. So videos that were shot talking about the intradermal vaccine to make sure that there was transparency. And I referenced another very important website, and I think, Rachel, what you said is so important is people want to know that this works. And so not only the intradermal, but the vaccine in general. So we actually will be putting up more and more data in a rolling way as it becomes available to make sure folks can see what we're actually learning in real time for how the vaccine performs, against a real monkeypox outbreak, as opposed to in lab-based tests that focus on immune responses. So there's more to come in that vein, but a lot of it has to do with, and also being responsive. That's the other part that we also heard from our engagements, that like people didn't want it on their forearm, so we got it off their forearm and gave them the other options. Like we heard people didn't want to do a risk assessment, so we got rid of the risk assessment. So all of it is really, really that iterative process of, again, science, community engagement, and political will to make sure that we can sort of provide what people need to address an infectious disease outbreak. Thanks.
Excellent. Here's a question from the live session today. My FQHC does not partner with Ryan White, but we do care for HIV patients in our infectious disease department. How would we get the resources to prevent, diagnose, and treat MPV? I think that's for Dr. Mufidi.
Yeah, I can take a stab at that. So so I don't work directly with the health center program. I work with the Ryan White, many of whom are duly funded health center program. My understanding is that the HRSA health center program funds can be used to support monkeypox testing and treatment independent of Ryan White resources. So they could use their existing H80, the American Rescue Plan, COVID-19 grant funding to support monkeypox testing and treatment, vaccine administration costs, for uninsured patients. So that's one part of the response. The other one is to really work with your state and local health departments for access to vaccine and therapeutics.
Thank you. So this could be for absolutely anyone in the group. Given that there's such a close association between HIV and STIs and MPV, what strategies are important to bring monkeypox testing and vaccination into a more primary care, comprehensive sexual health strategy? And if you have any recommendations of how to execute that, we would love to hear them.
I'll take a try at that. I think that I think that they have been integrated at this point, and it's about sustainability. I think it's ensuring that the staff have the training and the resources, as this has been an evolving picture, to keep MPV as on the radar as an assessment for both your triage team as well as your urgent care and STI clinic providers. I think it's going to be something that we are going to continue to see in the community. I would say, have only made it about a week and a half without a patient being referred for TPOXX treatment. And so here at Calum Lord, it has definitely been at the forefront still and ongoing. And I anticipate that to be happening for a while. What becomes concerning is when it does fall off the radar. And so I think creating infrastructure for ongoing and routine training and resource, assessment for MPV, both as part of routine primary care and as well as your urgent care and STI clinics will be important ongoing.
I want to emphasize the last point. I think paradoxically, as it has become less common, there may be less incentive for other clinicians to learn about it or to engage in the IND for tecovirimat, for example. We're seeing this in our program. We've prescribed about a third of all the tecovirimat that's dispensed in our state. We expect to continue doing it for those who may need it, but providing ongoing education and technical assistance to support other clinics in doing things like that. The testing, the treatment and other care, I think, is crucial.
So I'll just add, to supplement everything that was said, which I agree with, is also we have opportunities now with interest in monkeypox to try to push testing technology forward that will really ingrain monkeypox into some of the work that we do every day, even if monkeypox is not top of mind. So an area of emphasis in our sort of research universe is, can we develop multiplex testing that combines a monkeypox test with an HSV test, maybe a BZV test, and if we really cross our fingers and pray hard, a syphilis test, so that if you see a lesion, you can swab it, and even if you're not thinking monkeypox, you'll get the result, which I think is going to be a great way to identify really early cases, even when it's not top of mind. So this is an area of earnest pursuit for us at the White House to see how we can make that happen. And then also thinking about the question with asymptomatic, like, is there a role for like understanding different specimen types? Because right now we're doing lesion-based testing, but what about if there was a gonorrhea, chlamydia, monkeypox, trichomonas test? Like that could potentially identify folks early on. So these are all areas that are more on the sort of research, R&D sort of test development side, but I think directly sort of make the point that if it is in a syndemic, treat it that way and test that way. And so the easier we can make it for folks, the better it's going to be. So I think programmatically and technologically, I think that we've got to do some things to make sure that monkeypox stays on the radar, even if it's not on our day-to-day differential diet.
And just not to forget the social determinants of health, right? Addressing stigma, addressing housing, all of these could be barriers to receiving care and treatment for monkeypox. So, how to bring those elements, social determinants of health, into this effort to address monkeypox.
Sure. So I think that this is a related question. I know, our speakers come from larger urban areas for the most part, where they've seen a lot of monkeypox cases. But let's say we're in a much more rural, small town health center. Some healthcare workers all over the country still feel uncomfortable asking questions about sexual activity, sexual orientation, and gender identity. How do you think we can support with techniques or resources for health centers to sort of augment their entire program around doing outreach and evaluation, and then supporting these patients? Because of course we know that they exist everywhere and not just in big cities.
So, with regard to the sexual history, for example, the more time someone does it, I think the more comfortable it becomes. But also, I think, having questionnaires that all patients are invited to fill out. There's actually some evidence that within the realm of sexual health care, people are more comfortable providing this history on an electronic survey than face-to-face with a clinician. And so, instituting things like that, and there may be a wealth of information that is gathered there that can help with identifying appropriate screening tests, with provision of HIV pre-exposure prophylaxis and post-exposure prophylaxis and so forth. And so that may be one strategy to help gather this information that can be used for many purposes to help patients.
I agree with all of that. I will also just add, organizational campaigns, signage, digital signage that help create an environment that decreases stigma around these kinds of questions can also be helpful. But I really think it is training and competency and creating space for your clinicians to do role play, to ask difficult questions around where they are uncomfortable having these conversations. Because at the end of the day, so much of the trust that I see around patients asking questions are behind closed doors in an exam room with the MA doing vital signs or with their PCP. And we want to make sure that those conversations are informed and that our staff are really comfortable doing that, and investing the time and effort and resources toward ensuring that is, I think, an important initiative around NPV and, of course, sexual health in general.
And agreeing with everything that's already been said, I just want to add that folks should reach out to the DIS disease investigation specialists in your communities who do this every single day, have these conversations every single day. That's what they do. And they are a wealth of information, and more often than not, happy to have those conversations and give that peer-to-peer support.
And I'll add that NAC does work directly with ASTO. So if you're wanting to strengthen the relationship with your local public health agency, we're happy to refer you to ASTO to help make some of those introductions. We know that typically there is a relationship, but we know during the pandemic, some of those relationships have been strained because of the under-resourced nature of many of our public health institutions. Kevin, did you have some?
Oh, I was just going to say another resource is the National Network of STD HIV Prevention Training Centers, the NNPTC. I believe there are 8 regional training centers, and they really exist to provide training and technical assistance around sexual health care. And so can respond to kind of requests for assistance and training to help health centers and clinicians.
This is probably a quick one, and probably for our White House colleagues. During the pandemic, health centers had some struggle to know which patients were vaccinated of COVID because there are so many community vaccination sites, and we're seeing vaccinations continue to spread through other community sites and pharmacies, et cetera. Do immunization information systems support monkeypox vaccine data? And is that a way that health centers can know which patients need, for example, a second dose or haven't been vaccinated?
So these vaccine information systems tend to be very regional, but the answer is yes. These vaccines, because of the data use agreements with the states, are all being reported in the IISs. So that was an easy answer. They're in there. And so if they're queryable, you can query them to find out about, you or the patient can query them to find out or get proof of their monkeypox vaccination. Thank you.
Fantastic. Well, I think that this was an incredibly valuable panel. So I'll invite all the rest of us, all the rest of the panel to give us sort of their last words or recommendations. It sounds like we shouldn't expect that this is just going to disappear overnight. So maybe give us one of your best tips on how a health center could move forward and being a productive part of the response. I'll start with the White House team so that I don't have you all speak at once.
Sure. So I would say that that there is in Outbreak something that's called the U-shaped curve of concern, that as you have decreased numbers of cases, people start to actually pull back some of the response, and what happens is that's when outbreaks come back. And so I would say that this is the time to really put the pedal down to the metal and work on getting individuals who would qualify for vaccine vaccinated, because really at this point, our best offense is a good defense. And so really creating both the good messaging, keeping that messaging going, but also making sure that we that now that there is adequate supply of vaccine, that we get folks shots in arms. And I think, as Kevin said, like when you're talking to them about other things, when they come for that HIV test, cross-check to see, did you get that monkeypox vaccine yet? If not, we have it, or we know where to send you. So let's really push to get the last sort of push of people vaccinated, so that we are ready when the next introduction of this this virus happens in the country. Will be that that force field of immunity that we need, and that's not just one dose, but 2. I'll hand it back to you, Julia.
Great. Our colleague from HRSA, any final words?
Yes, to manage monkeypox as a syndemic, increase awareness, vaccinate, and engage in HIV care as soon as possible, and consider any suspicious rashes as possible monkeypox, and as was just mentioned, testing all sexually active patients with suspected monkeypox for HIV at the time of their NPX testing.
Wonderful. Anything from you, Kevin?
First, I would just say thank you to all the health centers for what they're already doing. And then second, I think it's so important to listen to what the communities that you serve are saying, and then to provide that feedback to your local public health authorities, because they do listen. And there have been several examples that you've heard about how processes and things have changed based on feedback, including the Tecovirimat IND, the availability of other sites for intradermal vaccine administration. So, these things do improve over time, but it really depends on kind of reporting what you're seeing and hearing.
Rachel?
I just have two quick things to add. I wanted to confirm with a colleague before I just offered this to the world. In regarding the question about sexual health histories in rural communities and having those conversations, NCSD does provide TA on that very subject through our Clinic Plus initiative. And so I'm more than happy to connect with folks who are interested in learning more about that. And the second thing is, I can't believe I haven't said it yet, there is a national monkeypox working group of organizations thinking really hard and trying to get some federal funding beyond the flexibility that's already been made available by the administration, which has been incredibly helpful. But as we know, we live in a culture of scarcity when it comes to public health. And so making our scarce resources more flexible is amazing, but it doesn't solve the resource issue. Kind of as a symptom, not the main disease. And so the working group is working as hard as we can to get some more federal funding for the monkeypox response, kind of harkening back to Demetre's earlier slide about the 4.5 billion. And if folks are interested in getting involved with that working group, I will put my email in the chat. But thank you so much for having me here today.
And Anthony, I know after Anthony's last comment, we do have a quick policy update from the NAC policy team. Go ahead.
I'll be super quick. I always like to remind everyone to share homework, copy homework. We are under-resourced oftentimes in this area as community health centers, and so build local networks with other CHCs, share policies, share best practices, share your workflows. It's always better when we're doing it together. Thank you. Thank you for having me.
Wonderful. And Malika Yawadad, she's from our policy team. She was going to give a quick update on what NAC's done on the policy side of things before we sign off.
Thanks so much, Julia, and thank you everybody for the wealth of information that you've provided and all of the great insight. I'm Malika Yadwad. I'm from the Public Policy and Research Division here at NAC. I just wanted to give a quick update on what's happening on the policy front with MPV. We've been continuing to hear about challenges from health centers with payment and billing for vaccine administration. We know that since the outbreak has started, a lot of health centers have also been administering vaccines through vaccine-only visits outside of the typical patient encounter. And a lot of these vaccines have also been administered by non-billable providers. And we're aware that the situation is different from state to state. Some states have been billing their fee-for-service rate. And there is currently not a supplemental amount on top of the PPS rate, similar to how there was an amount for COVID vaccinations. So we know that there's some barriers, that there's currently only an HHS public health emergency declaration. There is not a presidential declaration right now. So we just want to continue to hear from health centers and you all about what's happening in your state and issues that you're having with payment and vaccines. But on the legislative front, NAC has been made aware of two different pieces of federal legislation that are regarding monkeypox and future public health emergencies. So the first one is the Public Health Emergency Outbreak Activation Act of 2022. It's currently trying to be introduced by Representative Sarah Jacobs from California. It essentially aims to increase the payment PPS under the physician fee schedule for services treating infectious disease and public health emergencies. And there is a second bill that has been introduced by Rep. Kasten from Illinois with the purpose of directing unspent COVID dollars from the American Rescue Plan Act for monkeypox efforts. And as Rachel mentioned before, federal funding has been a real concern, and we continue to advocate for that. So that is currently been introduced in Congress. But we're continuing to monitor actions and legislative work. So if there is any feedback or anything you'd like to share, please do reach out to us. And thank you so much, Julia and the clinical team and everybody on this call today.
Thank you all so much for joining. I'll put my email as well in the chat if you would like to coordinate with our team. And please know NAC also has a monkeypox resources site on our website. You can just put that into Google, NAC monkeypox, and you'll find it's mostly a list of authoritative resources from other sites, like some of the ones on this call, but you can find those links there. Thanks so much for joining us.